it is my pleasure to introduce to you Dr. Brian Trimble. He is a neurologist at Alaska Native Medical Center with 40 years of clinical experience and a key contributor to the efforts by the Alaska Stroke Coalition to improve care for all Alaskans. I have to say, this morning we had an opportunity to visit his hospital and the whole campus of the Alaska Native Medical campus, basically. And I was incredibly impressed by the sense of community and the care for all Alaskans and the inclusion of all people in the processes, not only for patient care, but development of systems and even down to the infrastructure of the hospitals, as well as amazing art that we saw today also. So please welcome Dr. Brian Trimble.
Well, thank you, Carolina. So I'm going to talk about the other half of the population that lives outside the urban center that is a huge challenge when we're trying to treat acute stroke. I have two disclosures relevant to this discussion. First of all, I've been an employee with the tribal health system in Alaska since 1989. 23 years of that was as a commissioned officer with the Indian Health Service. And I and my colleagues, George Banks and Ryan Wilson, travel around the state on a regular basis to do neurology field clinics. So we're very familiar with the rural parts of Alaska. The second disclosure is that I was the principal investigator in the Alaska Native Stroke Registry, a 4-year prospective and retrospective population-based observational study of stroke in the Alaska Native people, funded by the National Institute of Neurological Disorders and Stroke. So what are social determinants of health, and why are they important? And how do they relate to stroke in Alaska Natives, particularly rural people? And so we're going to talk about that, the definitions. We're going to talk about a case that I presented to the Alaska Stroke Coalition a year ago, very well documented, an unusual case that helps you understand some of the challenges of dealing with stroke in rural areas. We're going to talk a little bit about, add to this development of a stroke systems of care in Alaska that incorporates different hospitals, populations, providers, and with regards to the social determinants of stroke. And we're going to look at a successful example of how RapidAI was used in a hub and spoke system in the lower 48. So the definition, what is a social determinants of health? According to the World Health Organization, it's characterized by where the person lives, where they're born, where they develop, and where they die. And these other environmental factors. Social determinants of health are the causes of disease. If you understand these big upstream problems or situations, you have a much better chance of making a difference in affecting a disease. This is relevant to cardiovascular health because the environment, the decisions people make have an impact on their behavior and what they choose to do, the foods they eat, education, work, use of tobacco. If you understand these, you can have a greater impact. These have been shown to be related to high blood pressure, inflammation, and chronic stress, and cholesterol that are important risk factors for stroke. And the Healthy People 2030 have made social determinants of health a priority. So let's look at a case. This is a 69-year-old gentleman who, from Point Hope, with a history of tobacco use, chronic hypertension, heart failure, chronic lung disease, and inactive pulmonary TB. The man lives in a remote area in Alaska. He has access, he's Alaska Native, he has access to medications, he has access to health care, even in this remote village, because there is a clinic there staffed by community health aides. And he has access to medications that he doesn't have to pay for. They're prepaid. He lives alone, he's self-employed, he may be an ivory carver. Subsistence lifestyle is very important. We'll talk about that some more. But at 8:30 in the morning, he suddenly develops left-sided weakness, face, arm, and leg, difficulty speaking. And the first thing he does is he goes to his neighbor and says, "I'm having a problem." Here is a picture of Point Hope in the upper part, and the lower part is the clinic in Point Hope. This is it's a population of 700 to 800 people. They do have running waters and flush toilets, something that we often take for granted, but to have a flush toilet above the Arctic Circle is an engineering miracle. When I started at A&MC, only about half the villages above the Arctic Circle had running water and flush toilets. There's a school there that educates people to the 12th grade. 60% of the people are employed in the public sector by the tribe, and the things that make the tribe work, like providing water and sewer and clearing snow. Subsistence is a very important lifestyle here. This is on the coast. Whaling is an important part of their lifestyle. Fish, hunting and gathering is very important, and making native arts and crafts, like carving ivory, is an important part of the economy. The only way in and out of this village is by air or boat. There are no roads to this part. This man is evaluated in the clinic there by a family nurse practitioner. So these are providers from the local regional hospital that make their field clinics out to the villages. So the specialists in Anchorage make it out to the regional hubs, and then the regional hubs providers will make it out to these smaller communities. So here is his vital signs, his symptoms. The nurse practitioner in Point Hope contacts the emergency room doctor in Kotzebue, the regional hub, and lets them know that sounds like he has a potential stroke. The ER doc activates life flight to leave Kotzebue, head out to Point Hope to pick up the patient. And they call, and the emergency room doctor in Kotzebue discusses the case with me, the on-call neurologist. We estimate the NIH stroke scale is between 3 and 4. It has important risk factors for a stroke, and I recommend that the patient be taken to the regional hub in Kotzebue. This is what we're dealing with. Point Hope is 148 miles to Kotzebue, and they've got to send a plane from Kotzebue to Point Hope to pick up the patient and bring him back. And then it's another 547 miles, a total of almost 700 miles from Point Hope to Anchorage. This is the distance between Seattle and Salt Lake City. I'm going to argue that bringing patients from these remote places to Anchorage, it takes up too much time. And we have to leverage the CT scanners that are available in regional hospitals to assess what is going on and where these people would be best treated. This is Kotzebue, the regional hospital that we sent the patient to. It is 26 miles above the Arctic Circle. It has a population of about 1,000 people. 90% of the people there are employed by the local native corporation, Manilak. Again, subsistence is a very important part of the economy. It does have EMS services. The Life Flight is based there. They have a hospital with doctors and nurse practitioners and many other providers. They have social services, tobacco cessation programs, physical therapy, long-term care, and they have protection of the state troopers are there. Unlike most of the small communities, there is no law, or very little law enforcement. It's village safety officers. And so it can be a problem. But there is access, and there's a CT scanner in this hospital that is able to do CT angiograms, and not yet CT perfusion, but they can do a CT angiogram. And this was done in this patient. In the time, this patient makes it into Kotzebue in the hospital in a CT scanner with 10 minutes to spare in the 4.5-hour window to treat with thrombolytic therapy. This doesn't happen very often in rural Alaska. The weather cooperated, the patient recognized the symptoms in time, we were able to get the patient in and get a CT scan, and the CT scan does not show a hemorrhage. Case is discussed with me, the patient gets tenecteplase and then gets a CT angiogram. There's no large vessel occlusion. Decision is made that the patient should come to ANMC, to our hospital, for further care and monitoring. But the time, the pressure is off. The patient has been treated appropriately. There's no other acute treatment that's available for this patient. And so it takes several hours for the patient to arrive in Anchorage. Arrives almost 12 hours after the onset of his symptoms, but he has been treated and he is improving. By the time he arrives in Anchorage, his NIH stroke scale is 0. And the workup begins. We repeat the CT scan. There's no acute changes, no evidence of hemorrhage. And we do an MRI scan. And the MRI scan shows multiple petechial infarcts in both hemispheres and both anterior and posterior circulation. This is an embolic stroke. The man had a cardiomyopathy, which puts him at risk of cardioembolic strokes. But his exam is normal by the time he arrives, and it remains normal. So he's treated with dual antiplatelet therapy, a statin, blood pressure medication, and he is discharged home with a cardiac event monitor. We can't totally exclude that he doesn't have atrial fibrillation, so that is looked for. Again, his NIH stroke scale is 0, modified Rankin score is 0 at discharge. And he needs to follow up with neurology and cardiology in 1 month. And unfortunately, he's lost a follow-up. We did not hear back from this gentleman. Must be a good sign. But this is the struggles that we have with providing this very sophisticated, amazing care that works really well in urban areas, but getting out to remote areas is a problem, where we see a different type of stroke. These people have their diet is high in fish and marine mammals, which protects them from the heart disease. We see very little large vessel artery disease in the native population, where it's very common in the Caucasian population. We do maybe 1 or 2 carotid endarterectomies a year for this reason, but they still have problems with hypertension. diabetes, obesity, tobacco is a very common problem amongst Alaska Native people. So understanding these social determinants of health help us to help them with and treat acute stroke. Well, where do we stand? Some things work. One thing that works is the Alaska Native people have taken over their own healthcare. It used to be run by the Indian Health Service, but in 1988, 89, it was turned over and it's totally tribal run. The tribe, we don't have the problem with discrimination in the rural parts of Alaska with Alaska Natives. And I will say that most of the people that live in remote parts of Alaska are Alaska Natives, but if anything, it's reverse discrimination. If you're Caucasian, you have more problems getting healthcare than the Alaska Natives do. There are clinics in almost every village, and these are staffed by health aides, people that live in that community, that know these people, and they're in contact with the regional hospitals. If there's a problem, they can be quickly sent into the regional hospitals and then from there into us, so a hub and spoke system of care. The things that we cannot change are the distances and the mountains and the oceans and the rivers and the obstacles that make it tough for people to come in. The weather, the presence or absence of EMS services. It can be very difficult to get these people in for acute care that is so time sensitive. But there's room for improvement. There are things that we can do that can be very, very helpful. So this is the spoken hub system of care that we have in Alaska. The circle there is a generous circle, and it incorporates the influence of the best medicine for acute stroke that we have to offer in Alaska. If you are within an hour from the Comprehensive Stroke Center, chances are you're going to greatly benefit from this new technology. Outside that circle, it's a different situation. Now, RapidAI has been very helpful in getting us to recognize acute stroke and get people to the care that they need. There are 3 ways that artificial intelligence supported imaging with these mobile platforms like iPhones and iPads have benefited acute stroke. First is artificial intelligence provides a rapid detection of abnormalities, difficult to see by eye. And when linked with these provider notification within minutes of the imaging being completed with these platforms of iPhones and iPads, the people that need to know about this case are notified immediately within minutes of imaging and can start planning and coming up with a cogent way of dealing with the stroke. The second is the support for clinical decision-making about appropriate acute treatment for both ischemic and hemorrhagic stroke is very useful, particularly in people who are presenting outside the usual windows of treatment, the 4.5 hours for thrombolytic therapy and the 8 hours or more for mechanical thrombectomy. Because of the CT perfusion studies, we can see select patients that may benefit from these therapies that are would otherwise been overlooked and not receive them. So these presence of mismatch and salvageable tissue has been very helpful. And if we can get RapidAI in all of these regional hospitals and get people to these CT scanners in a timely manner, we can better direct where they should go. If they have a large vessel occlusion, they absolutely should go right to the comprehensive stroke center. If they're within their range or they have salvageable tissue, no large vessel occlusion, they could benefit from thrombolysis. They can receive that in these hospitals that are all potentially acute stroke ready hospitals, be treated there and then come into Anchorage for the rest of their workup and care. And if they have a hemorrhage, which neurosurgeon is available to deal with the hemorrhages or subarachnoid hemorrhage? So I think the ability to have RapidAI available at all the regional hubs would go a long way to improve acute stroke in Alaska, in rural Alaska. So these are a summary of the social determinants of health as it relates to stroke and cardiovascular disease. We have a population that relies heavily on subsistence, which is protective for the most part, except for the tobacco and the alcohol that cause problems. Their education systems, we can improve health literacy, and the tribes are doing a great job in getting the word out about risk factors for stroke and heart disease and many other disorders. The poverty that has contributed to cardiovascular diseases in the rest of the United States is a little different in the rural parts of Alaska because of subsistence. It's a subsistence economy. You have to go out and hunt and fish and collect your food. It's not a matter of getting a job. It certainly is available, but it's limited, and it's not as important in some of these rural parts of Alaska. We have problems with violence, with crime, domestic violence, alcohol, drugs, substance abuse are problems. But we also have religion. A lot of communities have churches that are headed up by a native pastor, and religion is a very important and stabilizing factor in a lot of these villages. There is community support. A lot of these people will be discharged home with impairments, but there is, or has been in the past, an extended family that can care for that patient even though they have severe impairments. Well, I am going to close at that point. I thank you very much for your attention, and thank you.